Welcome to the Black Trust Podcast. Where we look at how the pivotal core capacity to trust will determine how African Americans show up in the movement to build a multiracial democracy, whether we are categorically diminished to survival mode or strategically and resourcefully innovate a pathway toward thriving. I am your host, Pamela Boyce Sims. I'm a clinical herbalist and wellness guide, practicing complementary integrative medicine.
If you cure somebody who has cancer that was not going to kill them, that's a pretty easy cure.
Welcome to an episode of the Black Trust Podcast entitled The Inside Story. What Black men are not being told about prostate cancer risk reduction, treatment, recovery, and resilient living. Shortly, we'll hear from the Senior Advisor to our Men's Holistic Health Project, Dr. Otis Brawley, who is the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. But I'd like to take a moment to share a quick story told by Dr. Brawley in his book entitled How We Do Harm. A doctor breaks ranks about being sick in America, in which he talks about how the medical system really views men who dutifully attend prostate cancer screenings. This story is about a conversation Dr. Brawley had with a medical marketing person at a cancer screening event about his business model. The medical marketing rep proudly recounted that of any given 1,000 men 50 years or older at your typical free mall or church health fair screening, 145 would have an abnormal screen. 10 wouldn't have insurance. The 135 remaining men would investigate the abnormal screen, and of those, 45 would have cancer. That medical marketer could accurately calculate the number of men who would have radical surgery, prostatectomy, how many would get radiation therapy, how many would get hormonal treatment, would have incontinence so badly that they'd opt to have an artificial sphincter implanted. He knew how many would experience erectile dysfunction and want Viagra, and also knew the percentage for whom Viagra would not work, and how many therefore would want penile prostheses. When the medical marketer was asked, how many lives will you save as a function of screening those 1,000 men? The marketing rep responded, "You've got to be kidding. Don't you know? No one can pinpoint if any of those lives will be saved. I can't give you a number on that." The mega profits in overtreatment, unnecessary procedures, drugs, and medical devices that cascade from a free health fair, mall-type screening, pad the bottom line of a long chain of medical businesses and is measured down to the very last penny. The system is structured in such a way that it encourages expensive overtreatment and unnecessary suffering with very little patient benefit. With that said, I'd like to introduce our guest, Dr. Otis Brawley, the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. Dr. Brawley is a renowned authority on prostate cancer screening, treatment, and health disparities. Dr. Brawley served as the Chief Medical and Scientific Officer and Executive Vice President of the American Cancer Society from 2007 to 2018.
It's wonderful to be here, and I wanted to talk about a little further about what Dr. Boyce Sims said in my book. That marketing guy knew how much he could make off of prostate cancer screening, how much money, but he, actually knew a truth. It's so important that we realize that there are many things that we've done in medicine because we thought it might be good, and then we found out it was not, and it was actually harmful. The other reason why I have been so outspoken is right now I'm actually in Kensington, Maryland right now. There's a group of urologists in this area, a large group of doctors who regularly pay Black ministers $2,500 to get the podium on Sunday, and then go get in front of the congregation. They especially start talking to the women to encourage their husbands and their men to go get prostate cancer screening. And what history tells us is for the longest time, Black men have not been respected and Black men have not been told the truth. Sometimes they've not been explained the truth. I'm going to tell you a truth right now. Don't tell him that it's like mammography for breast cancer or pap smears for cervical cancer or the numerous colon cancer screening technologies, or spiral CT for lung cancer in people who have smoked. All of those, we have science to show that those interventions prevent people from dying. Part of the problem with prostate cancer is there is a large number of people that have prostate cancer, and it's a kind of cancer that we don't talk about much. It's a kind of cancer that, if never treated, will never kill you. If you cure somebody who has cancer that was not going to kill them, that's a pretty easy cure.
What type of cancers will threaten men's lives and need treatment, and what types are better for surveillance?
Okay. When we diagnose a man with prostate cancer, the first thing we want to figure out is it localized to the prostate or has it already spread? If it's already spread outside of the prostate, that is more the kind of prostate cancer that can threaten a man's life. If it's still localized to the prostate cancer, we look at what is called the Gleason grading system. And that is looking at the cells under the microscope, and a pathologist can look at the pattern of the cells and say this is an aggressive tumor or this is a less aggressive tumor. And the less aggressive tumors, especially the less aggressive tumors in older men and men even in their 50s and 60s who already have heart disease and other things, the less aggressive tumors can be watched. Indeed, in the 1990s, and this is some of our lack of wisdom in medicine, in the 1990s, when we first developed this blood test to diagnose prostate cancer, we literally would say, gee, it's Thursday and you just got diagnosed with prostate cancer. You need to start treatment by the end of next week at latest. Now, starting about 15 to 20 years ago, we started, because of some studies done at the National Institutes of Health, some studies done in Europe, we started realizing a large number of men, especially these men who have the lower grade or lower Gleason score, the less aggressive tumors, can be watched. And if they're watched carefully, the majority of them will never end up getting treated with surgery or radiation. Again, it's not ignored, it's watched carefully over time. In one large study that looked at men who were treated, I do a lot of clinical trials, so I'm going to tell you one clinical trial here. They took about 900 men who had localized prostate cancer in the prostate, and they randomized a third to surgery, a third to radiation, and a third to watching. And of the 300 and some odd who were watched, 20% over a period of about 15 years ended up being treated because their tumor was growing. 20% ended up being treated because they just couldn't take, I have cancer and I'm being watched. They were treated for emotional reasons. So you have 40% treated over a period of 15 years. And the number who had died was the same as the number who had died in the group that got surgery or the group that got radiation therapy. And so we've got studies, that's just one, that tell us that if you watch very carefully, you can do this well. If this is among men who've been diagnosed, and it's very reasonable to say, if I have cancer, I want to know about it so a decision can be made as to whether I'm being watched or being treated. Therefore, I want to be screened. I don't want to discourage people from getting screened. I just want them to know the potential risks and the potential benefits and know that it's an individual decision a man should make.
What is overtreatment? What is the scope of that?
Well, overtreatment in my book, in certain other diseases, we do give medications too much. In prostate cancer, if you have a low-grade cancer that is small inside the prostate, and you have a man who's in his late 50s or early 60s, in my mind, to treat that with surgery or radiation is overtreatment. In this country right now, most of us let the man decide whether he wants to be observed or treated in that case. But quite honestly, surgery or radiation for that man is overtreatment.
Why do they do that, Dr. Brawley? Why is that so prevalent?
It's prevalent because ever since we were all on our mother's knee, we were told cancer is bad and the way to deal with cancer is to cut it out. And now you got this guy from Johns Hopkins talking about how over half of all the prostate cancers that we find are good prostate cancers, which if never touched, if you never told the patient that they had prostate cancer, God never intended for the patient to be bothered by it. And by the way, I can also tell you of how we got into it's safe to observe some of these guys. There's some wonderful studies that actually, ironically, ended up coming out of the crime epidemic in the United States. Weil Socker, who's a pathologist at Wayne State University, he's now the dean of the medical school there, in the late 1980s had a deal with the Wayne County coroner that any male body that came in for autopsy after death through gunshot or death through automobile accident, if the pelvis was not part of the criminal case, the autopsy was done And the coroner would send the prostate over to Wayne State University. And they started looking at the prostates of well over 1,000 men. And this is actually a question that shows up frequently on the board exam for urologists now. Of men in their 80s dying of heart disease or dying of auto accidents or dying of trauma, they're like gunshots, 70% have prostate cancer. Of men in their 60s, 50% have prostate cancer. It's this decade of life minus 10, starting with 30% of men in their 40s.
Wow.
Okay. Prostate cancer is incredibly common. And a study that I did when I was at the NIH in the 1990s, it ended in 2003, we found out that we could actually diagnose over a 7-year period of time through extensive screening, we could diagnose 15% of men with prostate cancer through extensive screening. And then we biopsied their prostates after, even if they had a normal screen for 7 years, we biopsied their prostate. And that's when we found out that we missed 14% of the men with prostate cancer. So what I just told you is if we got rid of the PSA test and just started biopsying men with prostate cancer, biopsying men's prostates, we can diagnose 29% with prostate cancer. And you didn't ask me, but let me tell you, slightly less than 3% of men die from prostate cancer. Okay? And so these are all some of the things that went into the realization that there are prostate cancers that desperately need to be treated and prostate cancers that desperately need to be watched. Not ignored, but watched. Now, I noted that of men who were observed, more than half at 15 years have not been treated. Okay, when a prostate surgery is done by a really good prostate surgeon, and we have some very good ones here at Hopkins, a really good prostate surgeon is a surgeon who 30% of the men who he operates on who could get an erection before the surgery are able to get are not able to get an erection after the surgery. 30% are rendered impotent by the surgery. That's when you have a good surgeon. When you have a good surgeon getting this surgery, about 30 to 40% have a problem in terms of urinary leakage. It may be a little bit of leakage, it may be stress, and when they laugh they leak, or it may be they have to wear a diaper. But 30 to 40% end up with urinary incontinence. And unfortunately, sometimes it overlaps. Somebody gets both of them. But those are the things that people complain about the most. Those are some of the harms. And if you got this treatment and you really didn't need it, that becomes over treatment. In radiation, some guys get radiation. Some of the side effects of radiation are incontinence. It can also go the other way, by the way. This happened to me last week. A fellow is unable to urinate. That's an emergency. Or you can have incontinence, you can have impotence. We have people who get radiation and have problems with their bowel because part of the bowel gets a little bit of the radiation, so they have radiation proctitis. Now, these are all things that can happen. They usually don't. But the things that are common are the urinary issues and the erectile issues.